So this is our 11th series since we started it. And today we have UNC hosting the hour for us. And the title of today's discussion is going to be From Research to Action, the Queen's Global Oncology Program in Cancer Care. And the moderator for UNC, who is going to be introducing the subsequent speakers, is Dr. Yuri Ferdolo, who is a professor of pathology and lab medicine at University of North Carolina at Chapel Hill. And just a quick one about him for those who don't know who he is. He does, of course, doesn't need an introduction in his field. Since 2011, he has been involved in UNC project with Malawi Cancer Center, and he has developed and supported diagnostic services, especially in the AIDS malignancy consortium space. And he is and has been the PI to multiple NIH funded clinical trials. Thank you again, Dr. Yuri, for joining us this hour, and over to you. Thank you.
Thank you. It's a real privilege to present to you, and the meetings and the work are incredible. So thank you to AORTIC. So first, let me see if I could share here, and do you see the correct version? Do you see the correct version? Okay. So today I'll be joined by Amun Chirwa, and who is a medical officer in the lymphoma program, as well as Maria Chikasimo, who's the lead nurse of our team. Recently, received her master's and is very interested in palliative care. And so, I would like to give and I will present on behalf of the graduate student who could not present that couldn't be here today to present the laboratory components. So I will give you a little bit of background as to how the program developed. That might be of interest to some. We all welcome questions and feel free to email or however you would like to ask questions, maybe in the chat or whatever is easiest. Um, the th this is something to this audience needs no kind of introduction or background, but for context, this is a map of a global HIV prevalence, and we know exactly where the global HIV prevalence is highest and continues to be highest. And Malawi, where we work as part of UNC Project Malawi, is obviously highlighted there, and that is again just for simple background. What is important is for this conversation is that the there is excellent HIV care in Malawi, meaning after ART scale up back in 2015, the prevalence of HIV has significantly improved, and the majority of those with HIV, of people with HIV, are on antiretroviral therapy or ART. I will say I will use people with HIV. I'll refer to as HIV positive for the appropriateness, though those are people with HIV. In Malawi still, and in much of the region, HIV is epidemic. And again, this is the kind of situation of the country in which we work with the population, and the this should be a population of 20 million, and the financial kind of overlays that we're dealing with or struggling with are listed here. So this has existed, and for many years, because of the HIV epidemic, the UNC has had a long-standing relationship with the Malawi Ministry of Health, and has been working in Malawi extensively. And because of that, it became kind of a natural extension to build on the HIV work to start understanding and improving cancer care. And this was not started by me at all. And I will give credit as often as possible, knowing without fail that many will be omitted who have had made significant contributions to the cancer work. What is known is that even with the idea that HIV is primarily still endemic in the southern African continent, uh, also, population growth is changing most dramatically in kind of a very similar region. And those two together, HIV, population growth, and aging, are all associated with that which we are all here to investigate and improve, which is the increase in the burden of cancer. And so these, again, to this audience that studies this and thinks about this and cares for patients with cancer on the African continent, this is not a surprise to us. But we know that the majority of cancer deaths they already occur, but an increasing majority of cancer deaths will occur in LMICs, and many LMICs are in the region in which we work. So that's the context or background on which a cancer work was started, in particular the lymphoma work. What we know is that HIV infection is associated with lymphoma for a number of reasons. And that is in partly due to decreased immune surveillance associated with T cell infection, oncogenic viral reactivation, which is its own separate interesting discussion, and persistent immune stimulation, all leading to an environment in which lymphoma is common. ART incompletely reverses these effects, and pre-ART there was over 100-fold increased risk of developing non-Hodgkin or common B-cell lymphomas. But even in the ART era, there is still a marked increased risk for developing non-Hodgkin's lymphomas. The most common in the world of lymphomas, and certainly in the HIV population, is diffuse large B-cell lymphoma. And that is true, again, irrespective of HIV status. DLBCL, or diffuse large B-cell lymphoma, remains a leading cause of cancer death for people living with HIV. So with that background, the expectation and hope was that if patients were in order to improve the care for patients with lymphoma in regions with high risk for lymphoma, we would probably need to start addressing as to how to start diagnosing these patients effectively. So what we knew prior to 2013 was that the overwhelming majority of patients treated for lymphoma in Malawi were treated based on clinical presentation, as there was minimal access to diagnostic services and pathology. In other settings, there is increasing sophistication of the different types of assays that could be used to treat these patients. But the reality is that even now, the majority of the diagnostics that we use here for treating patients relies heavily on pathology services. So with that in mind, the Kamuzu Central Hospital, which is the central hospital in which we work in the capital city of Malawi, was established in 2013 to develop a cohort of patients with pathologically confirmed lymphomas in the setting with high rates of HIV infection and severe resource limitations. This is where there could be a whole conversation about those that have influenced the development of these programs and improved care for patients. The program itself was started by now the director for the Institute for Global Health the Institute for Global Health at the National Cancer Institute, Satish Gopal. The leadership that has existed and supported the work in Malawi in the form of UNC Project Malawi, and our cancer center. This US supported project, UNC supported project, was in close collaboration with the Ministry of Health and Kamuzu Central Hospital itself. And I would say that some of the challenges that many of the programs that now face over the past 6 months in particular, I think some of the biggest detriment or risk is that there are um, so much of the work done in truly building partnerships is now a little bit more at risk, maybe a lot more at risk than it was before. So in 2011, 2 years before the initiation of the trial itself, Satish and others, and those here in the photograph, we established a pathology laboratory on the site of Kamuzu Central Hospital in some vacated space. And what was principally important was the fact that initially we started with the development of telepathology services, which allowed for review of cases of lymphomas and lymphoproliferative disorders, and enrollment onto this observational cohort that we hope to be the framework for interventional trials in the future. And that has gone on since. And so this telepathology conference that we do every Monday, we continue to do weekly to enroll patients. This has been a remarkable opportunity to build further collaborations, train pathologists, involve Malawian pathologists not only in the direction of the laboratory, but also in the development of their research and clinical interests as well. So this was the laboratory originally as it started with a basic equipment. Everything was done by mostly manually. And then again, because of this telepathology service, we were able to start enrolling patients with diagnosed lymphomas. And even within the first few years of study, this table demonstrates to you the types of lymphomas that we were able to enroll and follow, and we're able to diagnose pretty granularly the types of tumors that we maybe expected to see and some that we didn't expect to see. Um, we have significant follow-up for these patients. There's minimal loss to follow-up. And then many of the tissue is now sent to the US for genomic investigation. But with a recent grant and other initiatives, we're hoping to shift even the sequencing studies as well as the plasma and serum investigations to be performed at UNC Project or at the Kamuzu University of Health Sciences, the College of Medicine that is in the capital city of Blantyre. As maybe not surprisingly, the tumors listed in yellow are the aggressive B-cell lymphomas that are enriched for in the HIV infected or people with HIV, people living with HIV. And again, although these numbers have changed substantially, the distribution of different types of diseases of the types of lymphomas that we see is pretty much has maintained the same pattern. This has become a remarkable resource for the training of clinical investigators and basic science investigators as well. We will talk more about this in the uh, following sections, but there has been a lot of output from this group, and again, largely led by Malawian researchers that we were able to support, which has been the most fulfilling. The work of the pathology lab has led to expansion of the pathology lab services now at a building adjacent to the Central Hospital or on the campus of the Central Hospital and next to the country's first National Cancer Center, with a laboratory infrastructure that now looks very much like a laboratory in the US. Probably most incredibly has been the development of Malawian researchers and Malawian pathologists Tamiwe Tomoka, Maurice Mulenga, and Shiraz Khan that run the pathology services there, as well as Tamiwe, who runs the cancer program who co-directs the entire cancer program with me, breast cancer, interested in breast cancer, and Shiraz, who works on esophageal cancer as well. The lymphoma program has then helped to be the centerpiece for the Malawi Cancer Outcomes Research Training Program, which is a training program supported by the National Institutes of Health to train Malawian pre-doctoral and postdoctoral trainees in their own journey towards independent cancer research. Beyond the work that you'll see now, which includes not only clinical characterization, but also the other end of care spectrum, including palliative care, we have other opportunities to study unique features of lymphomas in the country. This is a map demonstrating the northern region of Malawi with the most green area here, highlighting where Lilongwe or the Central Hospital is. And we could even measure distance to travel or time to travel in relation to outcomes. So, for instance, those from the Lilongwe district have an improved overall survival. And again, there are a lot of nuances to that, but nonetheless. So that is the development of the project that I wanted to introduce. And next, I would like to introduce Eamon Chirwa, who is a clinical officer, a medical officer on our team, and runs and supports the lymphoma study.
Thank you very much, Yuri. Let me share my screen. All right. Thank you, everyone, for joining the meeting and hearing from us at UNC Project, talking about some of our work on lymphoma. So I'm going to talk about some of the clinical characteristics and outcomes of lymphoma patients that we've seen at Kamuzu Central Hospital as part of the ongoing lymphoma study in the Malawi South Africa UNC consortium. So as Porphyrias discussed, lymphoma is associated with HIV, and of all the lymphomas, the diffuse large B-cell lymphoma is seen to be the most common. And non-Hodgkin's lymphomas in general are quite common in sub-Saharan Africa. In fact, it's the sixth most common cancer. And fortunately, it's been shown that patients with lymphoma, particularly diffuse large B-cell lymphoma, can be treated with standard chemotherapy, even in sub-Saharan Africa. So overall, some of the goals of the ongoing study that has been going on at Kamuzu Central Hospital has been to characterize the features of HIV-associated diffuse large B-cell lymphoma, particularly the clinical, laboratory, and histopathological features. To correlate some of the prognostic markers, which are generally used in resource-rich settings, with patient outcomes in a sub-Saharan African setting, as well as to investigate other immunogenomic features of HIV-associated diffuse large B-cell lymphoma. This is a picture of the Malawi National Cancer Center, which is based at Kamuzu Central Hospital. This is a map showing the same Malawi National Cancer Center, more or less within the campus of Kamuzu Central Hospital, as well as its close proximity to the UNC project buildings, the annex, which houses the UNC pathology lab, as well as the UNC project Tidziwe Center. So that shows really the close collaboration that is there between with UNC and the Malawi Ministry of Health. So the KCH lymphoma study has been going on since 2013. It basically includes diagnosis and clinical follow-up of participants, standardized chemotherapy and supportive care, as well as other additional investigational studies. So essentially what happens is that a patient comes in with a biopsy or some result. That result is that biopsy is processed into tissue blocks, which are initially reviewed on site, I think with assistance of the telepathology conference to have a diagnosis, which is used for treatment. Later on, some of those samples or blocks are then shipped to UNC and maybe now other sites for further analysis to look at have a final diagnosis. So for the purpose of the study, there are three groups of participants that we have. We have those who are HIV negative. We have those who are living with HIV, in this case, HIV positive, but we have some who have been on ART for more than 6 months, who we've described as ART experienced, and those who have been on ART for less than 6 months at the time of diagnosis. Those we call ART naive. So based on previous data that we've followed up here at UNC, Kamuzu Central Hospital, we've seen that of all the subtypes of lymphoma that we've seen, the most common really is diffuse large B-cell lymphoma. This is the same regardless of the universal ART and the post-universal ART period, and it's still we still see that in large numbers of DLBCL for those who are either who are still HIV positive or HIV negative compared to the rest. So I think for the focus of my presentation, uh, I'm going to talk about this time period from about 2021 up until now. That was when we received a particular grant, one of the U54 grants. So we enrolled a total of 161 participants with lymphoma, of which 56 had diffuse large B-cell lymphoma. So about a third of the participants. The median age was 45, though we had more males than female participants, and most of the participants presented quite late with over 4 months of symptoms. Most had advanced disease, at least stage 3 disease, and over half of the participants presented with a poor performance status greater than or equal to 2. Almost 3/4 of the participants were HIV positive, and most of them were ART experienced with where they've been on ART for more than 6 months. The median CD4 was 183, and luckily most of the participants had an undetectable viral load. So for this particular group, from 2021 up until 2025, we see the 12-month overall survival period was about 38% at the 12-month mark, which goes down slightly to 31% at the 24-month mark. When we tried to separate these by HIV on ART status, we did not see a statistically significant difference, probably because there were fewer numbers for this particular group. However, I think when we look at some previous data, which we analyzed in 2013 to 2019, we see that in the long run, up to 5 months, participants who are HIV positive seem to have a greater survival probability compared to those who are HIV negative, and particularly those who are HIV positive and ART naive. And then overall, we also see that HIV positive and ART experienced patients have decreased viral load and increased CD4 counts compared to HIV positive and ART naive patients, as we would expect. So we also looked at some data on travel time for the participants coming to the clinic. So cancer care in Malawi and central regions of the country, the northern and central regions of the country, which include about half the population of roughly 10 million people, we only have really the National Cancer Center for most of the treatment, which means that participants have to travel quite long distances, especially for those from the northern region. But we see that throughout the study, 80% of the participants tend to come from Lilongwe as well as the adjacent districts. But that doesn't mean that, Lilongwe or surrounding districts see more lymphoma than the northern districts. Probably this may be a factor of participants either just not being able to, one, be diagnosed with difficulties in diagnosis, as well as difficulties in travel to finally get treatment. So I think overall, um, throughout the study, we've managed to characterize some of the features of HIV-associated diffuse large B-cell lymphoma, and we've also looked at some of the clinical impacts of HIV and ART on DL, BCL. So I'd like to acknowledge, I think, many of the players that have contributed to the study, as well as all these individuals on the screen. I think Prof. Yuri may comment more on some of the lab investigations. Thank you.
Thank you, Amon. So in order to please confirm this is the correct slide that you see. Everything is clear, right? Not the presenter view. I think it's okay. Okay, perfect. So what you see here is that as Eamon was discussing, and I'll try to keep this brief to demonstrate for you what we are trying to accomplish without necessarily going into too much of the data. So I'll cut down my bit so we can hear from Maria as well. But there are particularly diffuse large B-cell lymphoma as being a remarkably common lymphoma worldwide. A lot of research has gone into understanding how to prognosticate the diseases or how to prognosticate the disease. And so in other settings, there are a number of markers that can be assessed within the tumor in pathology laboratories, not only the clinical characteristics, but also in pathology laboratories that give a significant that holds significant prognostic impact. For the most part, patients are still treated with a standard combination chemotherapy and when available, rituximab, and that is the same for our setting in Malawi. The question is that let me see if I can do this. A review from just recently demonstrated that when just reviewing HIV positive, when just looking at HIV positive diffuse large B-cell lymphoma, while we know that the molecular features and the biologic features and the clinical features are different, very few settings have been able to investigate the significance of the biomarkers that we use in the relevance of the biomarkers that are widely used in other parts of the globe. And so having access to the investigations that we're doing and the data that we're generating, we wanted to see whether there were any differences or specific features of lymphoma that we could leverage both in the prognostication of these patients and in the development of future trials. This is the same slide that Ayman just showed you, demonstrating the lymphoma study as it stands. And importantly, I show it for the colors that are represented here, blue, this kind of pinkish, and red. And those will be the patient subgroups that we follow in subsequent slides. For information, again, HIV negative, people without HIV and lymphoma are in blue. Those that were on ART at the time of diagnosis are in pink. And those that were ART naive but but living with HIV at the time of diagnosis are in red. And we were able to perform evaluations of the different cell types that are present within the tumor microenvironment, all at trying to get at whether patients in these different cadres or these different clinical presentations may benefit from differential therapy in the future. Perhaps not surprisingly, what you see here is the number of CD4 positive T cells and CD8 positive T cells. And if we look across our three groups, the patients without HIV have the highest CD4 counts, which is even within the tumor, which we expected. And the patients that are most immunodeficient, most immunocompromised, have the highest proportions of CD8 positive T cells. This perhaps the CD4s are not surprising. The CD8s is certainly of interest, largely knowing that the CD8 positive T cells are those that are related to the immune response to tumor, etc. The We are able to look using this technique of cellular analysis. We were able to look further as to the different types of T cells that are present within the tumor microenvironment. And again, in addition to the overall CD4 and CD8 populations, we also see differences in functional T cell subsets that have in other studies reflected responses to or have logically driven the development of therapies for these patients. And so we asked, could these tumors be good candidates for immune checkpoint inhibitors, for instance, that are perhaps safer to administer, although currently more costly? Could this be an opportunity? And the way that we know checkpoint inhibition, that is the ability to modulate an immune response to tumor, to reactivate an immune response to tumor, has been shown to be very useful and life-saving for a number of tumors. And in the HIV negative, in the context outside of HIV, there's been inconsistent results and inconsistent responses to checkpoint inhibition. But we question whether the unique environment within these tumors could potentially promote an environment that is appropriate for treatment. One of the features that we review or look at is the interaction of these ligand of the PD-1 and PD-L1, which is an interaction between two cells that suggests that there is interplay between tumor and the immune response in a certain manner. And even from this image here, the images are different. When we look at the co-localization of the two markers suggesting cellular interaction of the type that could potentially be targeted by immune checkpoint inhibitors, we see that the yellow signal, the both positive, the co-localization signal, is more strongly positive in many of our people with HIV on ART compared to patients without HIV at time of lymphoma diagnosis. And these types of studies we can perform iteratively and expand the efforts to identify targeting features of these tumors. Before we go to Maria, I would like to demonstrate, I will skip over a lot of the lab portion to demonstrate for you another very important feature. We most recently, because of the work associated through the U54, through a U grant that Emon had described, had started investigating different, not only looking at the Malawi cohort that we have been establishing and supporting for a while, but then partnering with others in the region from South Africa in this case, and seeing whether there were shared genomic features between diffuse large B-cell lymphomas at both sites. While we found some features that are similar that also bring up a whole bunch of new, perhaps targetable ways to treat and identify these patients, we also found that there were significant survival differences in Malawi and in South Africa, which often, and we can talk about that more if you'd like, or again, happy to connect, which seem to reflect changes that are or seem to reflect structural differences with the healthcare system, not necessarily, and referral patterns, not necessarily not clearly with the biology of disease. Nonetheless, as Eamon had pointed out, we find it particularly interesting that our most immunocompromised patients at the time of diagnosis seem to have the best overall survival when treated with chemotherapy and antiretroviral therapy at time of lymphoma diagnosis. Again, there are far too many people to to thank, and that is true for all of the work that we have done. But in order to leave time for the palliative care portion, I will stop my share and introduce Maria Chikasima, the lead nurse of the lymphoma program, as well as a palliative care specialist.
Thank you very much, Yuri. Let me share my slides. So thank you everyone for joining the meeting. I've been already introduced by Yuri. I'll take you through about palliative care as one of the treatment options for cancer treatment. So part of background of palliative care in Malawi, like other countries in sub-Saharan Africa.
Maria,
Yes.
can you put it on the presentation mode?
Okay.
On the bottom right, kind of by the minus sign.
Mambove, tazanithandiza. Mwamva, tazanithandiza.
Yeah, keep going to the bottom right. Keep going. On right where it says like notes, comments, and then
Give a presentation mode.
there's a
Yeah.
yes, that one. Yep. That'll do it. Yes, perfect. Thank you.
Okay, so Malawi, like other countries in sub-Saharan Africa, is still faced with HIV and AIDS epidemic, plus cancer and other communicable diseases. So it is estimated that about 25,000 Malawians live with cancer. And in 2002, Malawi government recognized palliative care. And the first center was established at Queen Elizabeth Hospital, which is the central part of Malawi. And since 2014, Malawi has national palliative care policy. And now Malawi can handle palliative care patients utilizing a holistic approach, which encompasses physical, psychological, spiritual, and social impact of the patients. As already explained, lymphoma is one of the most common cancers among young adults in sub-Saharan Africa, but survival rates are much lower than elsewhere in the world. And we have seen that there's poor outcome in low resource settings, often due to treatment abandonment, due to side effects and toxicities, with limited access to symptom management medication and palliative care support. So because of that, we had to have a study of which its objectives were to demonstrate feasibility of a symptom management toolkit designed for cancer care in sub-Saharan Africa. So we had to measure the impact of the symptom toolkit on health-related quality of life using the Chichewa pediatric patient-reported outcome measurement information system, version 25 profile, and on symptom management using the Chichewa pediatric patient-reported outcome version of the common terminology criteria for adverse event. Sorry. So in Malawi, we developed that a novel symptom toolkit where there was inclusion of medications to manage some of the most common symptoms experienced by adolescent and young adults with cancer. And we had pictorial medication labels to aid patients and their families in understanding which medication to use for which symptom. The symptom toolkit was given to patients with lymphoma enrolled in a lymphoma cohort, not from any other type of cancer. We concentrated on the lymphoma cohort, and we are giving education and counseling on its use. So the patients were receiving the symptom toolkit journal, which had pictorial booklet with visual explanations. I will display the visual later. Then we had also a symptom toolkit diary to record when symptoms were experienced and medications were taken. So the medications themselves were labeled with pictorial created by a graphic designer, and there was an education intervention from a palliative care receptionist. So the palliative care receptionist did symptom assessment upon initial chemotherapy treatment, mid-cycle, which is cycle 4 of chemotherapy, cycle completion, whether it's cycle 6 or 8 accordingly, and every 6 months during follow-up until completion of 5 years, which was the follow-up period, or whether death or until when the patient dies, that is. So here is one of the picture. We were concentrated on 6 symptoms, and these 6 symptoms, we obtained them through focus group. We had a focus group of lymphoma adolescent young patients, and during interactions, they discovered that the most 6 symptoms were the ones affecting them. So we concentrated on those 6 symptoms. So this is a picture. When we have a patient, after explaining everything, we would ask the patient what the patient can refer to this symptom. So as you can see in the picture, this symptom is for nausea and vomiting, and I think it's self-explanatory. And we have another symptom, which we always ask the patient, what could be this symptom? So most of the patients were able to see that this patient is straining to defecate, and this is a constipation symptom. This symptom stands for pain. We failed to come out with a proper illustration of pain. So this was meant for pain for our illustration. And this one, if you can see properly, there's redness in the mouth. So this symptom is mucositis, which is very common for patients who are getting chemotherapy. And this one, as you can see, the patient is sleeping, but there's a close, meaning that the patient is failing to sleep. So this symptom is insomnia. And this one, as you can see on the illustration, the patient is holding her abdomen, and this symptom is gastritis. Now, we had a diary, a journal with this page. So I'll try to explain to you. Here, it's written in vernacular because that was what we had to explain to the patients. So chemotherapy is given either weekly, fortnight, or every 3 weeks. So this symbolized first week post-chemotherapy. This one is second week post-chemotherapy, and this one is 3rd week post-chemotherapy. So when the patient was enrolled in the symptom toolkit, immediately was given this diary. And this symbol where you see the face smile, it symbolized that the patient had no side effect. And this face, which shows sad face, it shows that the patient had a side effect. And this is a symbol of drugs, which means on daily basis, the patient was supposed to assess himself or herself whether she or he had pain, whether she had nausea and vomiting, constipation, mucositis, insomnia, and by the end of the day, especially maybe in the evening, they were advised to cycle. For example, if the patient had pain, that means the patient was supposed to cycle this sad face, meaning that she had pain. And if the pain was not severe, that she didn't take medication, she could leave out the drugs uncycled. But if the patient had a symptom like pain and she has taken the medication, she could cycle the sad face, meaning she had a symptom, and she could as well cycle the medication, meaning that she took the medication. So the patient was doing this assessment on daily basis until she comes for next cycle of chemotherapy. On the same diary, here, we were teaching the patient to use some natural medicine. In palliative care, we allowed or encourage our patients to use natural medicine as long as they do not harm. So in case the patient had a symptom and she has used a certain natural medicine, we were asking them to indicate here, to write the symptom and the natural medicine which was used, so that we were also learning and we were also advising other patients to use the same as long as there was no harm. Apart from natural medicines, there was also life modifications. So, for example, if the patient is experiencing a lot of nausea and vomiting, the patient could use little fats in diet, and the patient could avoid bad odor. So everything which was modified was also written here so that we can learn and teach other patients. So this was done on daily basis until next chemotherapy cycle, when we were recapping and see what side effects these adolescents were having, how they were medicating themselves, and how effective were the medications. So, as part of what I've already explained, I'll just give an example of the nausea and vomiting. At first, we were defining to them what does nausea and vomiting mean. So, as here, nausea or vomiting are very common symptoms to experience when they have cancer, especially when they are receiving chemotherapy. The pharmaceutical medication which was providing was either promethazine and ondansetron. And on the natural medicine, we could encourage them to use ginger, tamarind, and baobab fruits because of their sour nature. And life changes is to eat small but frequent meals, avoid fatty foods, and avoid bad smells. So we were counseling the patients. I've already said that when we know the patient, we were showing them the pictorial pictures, and the patients were asked to identify the symptom from the pictorial pictures. So others, they could miss, but we were able to tell them that this picture meant for this symptom. So that was confirmation and correction of the symptom identified by the patient. So each symptom was being defined to them, and we are explaining on how the patient will cycle their symptoms and taking drugs. We are demonstrating on medication pills in relation to their symptoms, and we are encouraging the patients to come to hospital immediately if symptoms persist. And we are assessing patients, their understanding, by asking the patients to recall. Patients were advised to write down nature medicine and other life changes, as already explained. But let me be frank here that in terms of pain, the patients were just given paracetamol because if they are in severe pain, we are encouraging them to come to the clinic as soon as possible so that we can assess their pain and see whether they are fit for morphine, which is a strong opioid. And if the patients are having fevers, we are encouraging them to come as soon as possible, as we were suspecting neutropenic fever, which is an emergency in patients with cancer who are getting chemotherapy. So you can see we were giving paracetamol not to inhibit fever and encourage them to come if they have severe fever and if they have severe pain. So our findings were that we found that the symptom toolkit were user-friendly because they could medicate themselves at home without visiting the hospital. And it was culturally acceptable because there was no stigma reported. And the symptom relief leading to improved quality of life, which led to adherence to treatment and preventing the symptoms to become severe. These patients, the adolescents, were able to assess and treat their own symptoms at community level. And there were few or no hospitalizations and sick visits because they were able to treat some of symptoms at home. As already explained, there was reduced stigma through enhanced socialization and better quality of life and adherence treatment as a result of symptom relief. And drugs were easily accessible. There was lower the cost of purchasing medications and hospital transportations just to get medication for their side effects. And we were privileged to learn about the natural medicines and able to share with others. So our preliminary results was that we enrolled about 65 adult young patients with lymphoma, and the median age was 39. They completed a total of 602 assessments. Remember, we are still continuing with assessment from enrollment, cycle 4, completion, and every 6 months up to 5 years period. So the diagnoses were acute lymphoblastic leukemia, Burkitt's lymphoma, diffuse large B-cell lymphoma, Hodgkin's lymphoma. And based on the symptom experiences, pain was 91%, nausea 71%, mucositis 65%, constipation 58%, insomnia 57%. And participants reported frequent use of their medication as needed from their symptom toolkit. So nausea were like 75%, constipation 75%, pain 85%, mucositis 89%, insomnia 65%. So analysis of health-related quality of life outcome measures is still underway. Future directions. We are thinking of adapting of the symptom toolkit for adult advanced cancer patients, planning to use participant advisor groups to assess the symptom toolkit. And we are thinking of having a pilot intervention trial using the symptom toolkit in adult advanced cancer patients, since we only done for lymphoma. while assessing feasibility and acceptability in the patient population. Thank you for listening.
Thank you so much for that wonderful presentation. Thank you, Dr. Yuri and Tim. I would now open the floor for questions and comments from participants for our presenters. So as you're waiting for questions and comments, I hope everyone is preparing to go to Tunisia. Oh, Professor Williams, please. Floor is yours.
Thank you very much. Well, I'm speaking from Canada, from Victoria, Canada, and my question is for Dr. Dr. Yuri, right?
Mm-hmm.
You did mention that rituximab is not routinely given for the management of diffuse large B-cell lymphoma. It's something that's now been in practice in developed countries for almost 40 years. And yet, you mentioned that you're studying immune checkpoint inhibitors in the same population. So I find it very difficult to understand what is the indication of studying a drug that is not likely to be in use in Malawi, in the same population that is not being managed with a standard of care that has been in practice in developed countries over the last 30 to 40, 50 years.
Yeah, that's great. So thank you for that. So our intention is always to treat the patients with diffuse large B-cell lymphoma with R-CHOP, with rituximab and the chemotherapy. The rituximab itself is very difficult unless even the biosimilar is very expensive. We have shown rituximab in our setting from our group to be safe and effective as well in HIV infected people with HIV and lymphoma. So the goal is always to treat them to get everyone to the standard of care, R-CHOP. The question is, it's just like when we see parallels to the way that HIV care had been developed, there were things that were completely impractical to do globally, let alone in Malawi. But the trials need to be done to understand which therapies could work or should work in these populations. And maybe that will help us either identify less expensive, safer therapies or argue for better pricing for therapies that could be effective. You're absolutely correct. In terms of standard of care, if we had
I agree. I agree with all that. But most of your patients are not HIV infected. So I'm not talking about HIV positive, like the cell lymphoma. I'm talking about the standard of care in Malawi for the management of large B-cell lymphoma. It seems to me to be suboptimal. And yet we are looking at the use of drugs that are not even affordable in developed countries.
Yeah, so it's the same.
Pembrolizumab and nivolumab.
Yeah.
It's the same.
It's the same argument. We on our clinical side, our attempt is to get R-CHOP for all patients, irrespective of HIV status, for our patients with lymphoma in Malawi. That is unquestionably our goal. That is not I don't know if that's the future in any setting, but it would be unfortunate to not understand whether that could be whether those kind of therapies could be adopted in Malawi. Also, there are ancestral genetic ancestry differences with the types of mutations that are present in African population, both from East and West Africa, in large B-cell lymphomas. Some of those are targetable pathways that the drugs themselves aren't being investigated because those of African ancestry aren't even represented on clinical trials in the US and clinical studies in the US. It is the opportunity to learn more about the diseases as it pertains to a population that is of greatest need for that, not in the short term, but in the long term.
Thank you very much. Do we have any other questions? I know we are about 4 minutes past the hour. I like not to, I'm conscious and mindful of our time. At this point, we're all preparing to go to Tunisia, in November. Bemora, who is doing next? But as we are thinking of going to Tunisia, we actually do have a North American series session, and we have some write-up. We'll try to send it out to everyone on our team if they're interested to being part of it, as we tout collaboration and partnership from the North American team. I'm trying to showcase our collaboration amongst ourselves and also the work that we have been doing. So it's a 2-hour session, and I think it's the last day. I'm trying to put it on the last day of AORTIC, and it's just going to be the first hour is going to be for our collaborators within the African continent, and the next hour is going to be amongst us here in North America. And I think one of the things we're going to be trying to talk about is funding in this era. So we are open to other suggestions, discussion, and we're just going to be keeping it open. So again, thank you again for joining us this hour, and we look forward to meeting you again same time next month, first Tuesdays of every month. Again, and goodbye for now. See you next month. Bye-bye.
Thank you. Thank you, Abiola.